Okay, so the dental X-rays. Now let's talk about the dental X-ray. Is there any fear from the dental X-rays? Tell you the truth, when it comes to dental radiography, we are lucky because we are dealing with uh, uh, the doses which are given in the dental practice, especially the periapical. If you follow the proper techniques and if you use the sensors, the dose is minimal, provided that there is justification. We're not doing chest X-rays. We're not doing CTs unless on need. But the doses, even the OPG, is the lowest within the medical practice. But this does not mean that we misuse or abuse the dental X-rays. Let's have an idea. The dose to the prenatal dose, or to the prenatal or to the fetus, let's say, from most properly done, that is following the first justification, proper placement of pen, proper placement of the cone, proper technique. So you need not to repeat, provided that you need that X-ray. Diagnostic procedures present no measurable risk of prenatal death, malformation, or impairment of the mental development. If you follow the proper technique, there is no fear on the fetus, either in cases of death, malformation, or impairment of the mental development. The fetal dose from a dental X-ray exam has been estimated to be between 0.25 microsievert and 1 microsievert. That is very much less than the daily background dose. The fetus is sensitive to ionizing radiation. However, the amount of exposure received by an embryo during dental radiography is extremely low, and there has no incidence that has been reported of a damage to the fetus from the dental radiography. So the comforting news is that the dose, if you follow the proper procedures, the fetal dose is minimal. Okay? And there has no reports so far reporting a fatal effect from dental practice. Good news so far. Typical doses from dental radiographical procedures. Let's have an idea. Intraoral dental X-ray imaging procedures, single X-ray, ranges between 1 to 8 microsievert. Panoramic, 4 to 30 microsieverts. Again, this depends on how long is the exposure and the radiation protocol. There are some panoramic machines that you can section. Suppose you want only the right, you want the left, you want the TM joint. So this, of course, will decrease the dose. This is the maximum dose for a full scan. Cephalometric examination is even less, 2 to 3 microsieverts. CBCT, here the number increases. Procedures vary between 34 to 652 microsievert for a small dental alveolar volumes, while the craniofacial, that is the full craniofacial view, ranges between 30 to 1079 microsievert. So, looking at these numbers, you see that we can say, okay, we can conclude. Let me keep my exposures to the periapicals. If they will do the job, then okay, I'm happy because I'm ranging between 1 to 8. Now, if this is not enough, like the periapical will not cover the area, I may increase the number of periapicals. But if I find that an OPG will cover the whole area, then I will go for OPG. Now, in certain instances, when you really need a 3D examination, CBCT, then you have to have a proper justification that you will do the examination. And of course, you should expect a dose ranging like from at least depending, you know that CBCT machines now you can have a very small area which is just exactly the same size of a periapical film, or you can have a craniofacial view. So if you have a full craniofacial volume, then you are exposing your patient maybe 20 to 30 times to that of a full OPG. So please make sure, decide beforehand what type of exposure you need and keep it to the minimum. Now, let's go to the X-rays during pregnancy. As we said, the dose to the fetus of a patient exposed to a full mouth examination, that is around 14 films, is less than as we said, 25 microsievert using lead apple. The dose to the ovaries from a full mouth exposure is about 2 microsievert. Why? Because the ovaries are far away from the field. We're not talking about an abdomen X-ray. We're talking about an X-ray that is far from the ovaries and the fetus. And the fetus is actually located deep inside the uterus, which provides further protection for the fetus. The risk of genetic abnormalities when using e-speed or digital X-ray is 5 in 10 million. And this is based on the estimations. There is no, as we said in the previous slide, there is no so far linked dental X-ray exposure and fetus abnormality in a pregnant lady. If you compare this number to the natural frequency of genetic abnormalities or cancer induction at birth, this is 1 to 3 in 100 births. See the amount of difference. This you can relate, you can discuss this with your patients, telling them what is the rate of abnormal genetic abnormalities in a lady giving birth compared to that of the expected genetic abnormalities from dental exposure. Of course, this is on a statistical analysis based on the amount of the X-ray that is, or the dose of the X-ray given. However, you have to have your precautions. Radiographic examinations should be kept to a minimum. This is a must. As with any patient, radiographic examination is limited during pregnancy only to cases with a specific diagnostic or a treatment indications. We don't do X-rays just for the sake of X-ray. You need them. This is what we said as the justification. And if optimal radiation safety techniques were followed, intraoral or extraoral examination can be safely performed. Regardless of pregnancy or a normal patient, we should follow the very famous ALARA principle, which is keeping the radiation as low as reasonably achievable. ALARA, actually, this is the key role in saving all patients and staff from unnecessary exposure to ionizing radiation. When it comes to safe radiation hygiene measures, protect your patient. Most importantly, justification. does the patient really need the X-ray? Never to forget to use a lead apron for your patient. Use the X-ray technique that gives the needed diagnostic information in only. You don't need to extend to other areas if you don't need them. No need for extra views. Minimize your exposures. Use the fastest film available. Preferably go for digital sensors because those need the minimum amount of radiation and they are very fast. And better still, of course, move to the digital sensors. Now the digital sensors are becoming a normal practice because it eliminates dark rooms and processing solutions, all this mess of the earlier days. It has become obsolete now, so we will go to the digital. So a justification is a key factor here. After, if the exposure is needed, then you follow with the proper techniques. When it comes to protection of yourself, female staff, inform your superior when you are pregnant or suspect pregnancy. Never hold a film, never. And this practice, unfortunately, I'm seeing this over and over and over again. Don't hold the film for the patient. Now you say that, okay, it's a short exposure or the X-ray will not be good, the patient cannot hold the film. I advise you to go to use sensor holders. Sensor holders will eliminate all this. See, sensor holders, in terms of infection control, they are the best because you're not contaminating your finger. The patient, if he holds the film, will contaminate his finger and then he will spread the infection. Okay? Sensor holders align the sensor and the tooth and the X-ray in the best alignment, so it gives you the best image in terms of geometry of the image. So there's no repetition, no cutting, no elongation, no nothing. So why would you hold the film for the patient? Go buy yourself a sensor holder. There are disposable sensor holders and there are sterilizable ones. Never hold the X-ray tube during the exposure, and this figure, keep it in your mind. Stand at least 2 meters away in a circle around the patient's head, because beyond this 2 meters you will receive no radiation. Okay? Whether you're pregnant or not. 2 meters. And stand behind the lead barrier if you have space. If you don't have 2 meters, you stand behind the lead barrier and watch your patient through a leaded glass, and don't go inside the X-ray room unless needed. There is no need to be in an X-ray if you have a separate X-ray room. Okay? So these are the golden rules in protection of the use the shortest exposure time provided, keeping in mind the best image quality. Don't overexpose the patient. Avoid repetitions. And as I said a minute ago, use a sensor holder, because this will ensure the geometry of the sensor and the film and the X-ray, of course. Avoid repetitions, angulations. Master your film processing if you're still doing processing. Master your computer skills so that you can you eliminate computer literacy, so you know how to deal with the computers, and only concerned patients should enter the examination room. There is no need for other persons to be inside the room during the X-ray exposure. Why would they be there? Unless they are needed for a reason, like in very small children or in elderly patients. Otherwise, everybody should be out of the treatment room when there is X-ray exposure. If in cases like a patient need cannot hold the film by himself, like in very young children or in elderly patients with physical impairment, then the relative should hold the film or at least support the jaw of the patient. But in this case, you have to put a lead apron for your patient and for the person who is accompanying your patient, because he will be exposed again to the radiation. So, in conclusion, you have to verify pregnancy. If you have to justify your X-ray exposure, protect your patient, protect yourself, and protect your staff. Thank you very much. And these are the references that were used in this lecture. Thank you very much.